The other day, I was watching this random documentary on the Minoans who built this
Mhm.
whole underground city that was buried. They think it was because of a volcano. And I was just thinking, I'm wondering, they're like, oh yeah, it's 3,000 BC. And I'm like, 2,000, 3,000. So that's like 5,000 years ago. And that they've got a sewage system, they've
Mhm.
got pottery, language, what looks like math. There was a whole community and a city built with sanitation and less disease 5,000 years ago. So it just made me put things into perspective because I'm thinking about like the DSM from like the 1950s and the 60s. Like there's a lot more to this.
Oh yeah, yeah. I think about that. In a couple hundred years, like how people will laugh at how we see things now. And a few hundred years ago, we were in the humoral world and doing bleedings and
Right.
vomitoriums and all that. So
Yeah, the
yeah, science
vials.
advances.
Yeah. Welcome to the Good.Enough.Shrink podcast. We are your hosts. I am Jenna Chang, a child, adolescent, and adult psychiatrist practicing here in Los Angeles, California.
And I'm Dr. Patrick Kelly. I am also a child, adolescent, and adult psychiatrist practicing in the Los Angeles area.
We are on a mission to demystify child psychiatry and have conversations surrounding difficult topics on youth and adult mental health, but not without a little play along the way. Okay, so today we're talking about bipolar disorder, which is a very complex and severe psychiatric condition. It is one of the leading causes of disability in youth globally. We're going to be talking specifically about pediatric bipolar disorder, but inevitably we do have to discuss adult bipolar disorder. That was the initial kind of conceptualization and study started with adults, but we are talking more about pediatric bipolar disorder.
Yeah, and I think all of the data and evidence, just because psychiatry's studies were mostly done in adults, and frankly, a lot of the controversy comes from the idea of what does this look like in kids? So we have to sort of start the grounding in where was this first diagnosed, so in adults, and then work backwards and see what it looks like in childhood and, well, actually, arguably in childhood and in adolescence.
Right. This topic, I think it constantly makes you re-examine the whole culture of psychiatry because it's debated and the conceptualization is always shifting. There's so many strong voices on either sides.
Right.
And so it was quite fascinating to read about. I honestly am not sure. Like, I don't know if I have a definitive answer. I do know I lean one way, but yeah, it's quite complicated.
Yeah, I think it's like a lot of things where the pendulum keeps swinging, and there are very smart people arguing on all sides of the issue. And so it's not about finding the loudest voice or the smartest voice. Where I've come down is really trying to be as careful and cautious with the person sitting in front of me as
Hmm.
possible. It's so easy to generalize, right? And to
Hmm.
say, well, I've seen so many bipolar cases, supposed bipolar cases that never turn out to be true. Or on the other
Hmm.
hand, I've seen so many low functioning, aggressive,
Hmm.
so-called depressed kids. And now that my eyes are open to the idea of bipolar disorder, I really see it. And we're missing all of these kids and we're doing such a disservice. It's so easy to fall on one side or the other and make these broad overgeneralizations. But I think the truth is that we have to be comfortable with diagnostic uncertainty. In the medical model, it is so frowned upon to not get to the diagnosis first and to not be certain about what you're doing and to not let the diagnosis guide treatment. But there has to be a degree of openness to we're still collecting data and we might find new information that leads us one way or another. And we can't say that I see you at 12 years old and now and forever you have or do not have bipolar disorder.
Yeah, it's just a snapshot when you meet them. We don't live with them, we don't see them day in and day out. So it's really important to make it a process of exploring and assessing. Yeah. So it's about 2% of the pediatric population that is thought to have an episode of bipolar illness by the time they enter adulthood. And two-thirds of adults with bipolar disorder reports that their symptoms began before 18 years of age. It is very much a debilitating condition. And it also affects the entire family, extended family, not just in the way that they interact with this person, but also there's a huge genetic component. There is a pretty significant delay in diagnosis of bipolar disorder for adults. On average, it's anywhere between 5 to 10 years. So that also suggests that there's delays in the pediatric population as well.
Right. And that's from first episode. One thing that we'll get to is bipolar disorder. The first episode, a lot of times, is a depressive episode, even though the course is to lead into bipolar disorder. So that's part of the delay, is that a lot of people are diagnosed with major depressive disorder. So again, it's not, you're sitting there with a broken arm for 10 years and just no one happens to see it. It's that it's a complicated course of illness.
Yeah, speaking of the course of illness, that's exactly what people were looking at historically. So we're going to dial all the way back to the 400 to 300 BCE. That's when they first documented the two extremes of mood. So this is around the time of Hippocrates, and people were trying to describe personality using these hypothetical humors of the body. If any of you are familiar with the perspectives of psychiatry, you may have heard these different terms. So choleric is a type of personality, phlegmatic is another one, sanguine, and melancholic. So choleric, which is closer to the meaning of like irritable, and phlegmatic is closer to unemotional, kind of avoidant. Sanguine meaning very positive, and then melancholic meaning sad. And they all encompass different levels of human emotions, and it's on this dimensional analysis. And it's interesting because, they thought that, for example, melancholia, melas means black and chol means bile. So it was believed that melancholia was due to excess black bile, whatever that means.
But I think that's just fascinating, really.
Yeah.
Like the fact that, even today, how many thousands of years later, we've come back to the four quadrants of human experience in describing personality. Yeah, we have different theories about the cause of it, but the phenomenology, what you see in people, we're sort of back to talking about the phlegmatic personality type. Not in those words. We don't think it's from excess phlegm, but that all people have these four characteristic quality groups. And when you have too much of any one, it can get you into trouble. I just think that's really cool that there's something true about this, that we've been talking about it for, 2,500 years at this point.
Yeah. The idea of needing that sort of biological basis has always been there, right? There's some humor, some like fluid flowing through your body that's causing this. And so they did make it a point to say this wasn't like a reaction to a situation. There was a distinct biological cause. They really wanted to emphasize that. And then skipping ahead, there was a French doctor who believed in a psychiatric disorder with both mania and depression, which he termed foyer circulaire in 1851. That was my best attempt. Please forgive me.
I don't speak French either, so I cannot help you with that one.
Yeah, but 1851, so we're really jumping ahead here. But there was something about the recurring and remitting psychiatric mood condition that they noticed. And then we have the great Emil Kraepelin in 1893. Great because he was a forerunner in identifying these diseases. So he tried actually to combine all dysfunctions of the mood, including mania, depression, and psychosis, into something called dementia praecox, which today is more known as schizophrenia. And then separate from that, he termed a condition called manic depressive insanity. This is more known as bipolar disorder today. But he actually never fully detailed the diagnostic features of dementia praecox and manic depressive insanity. So they kind of had to gather clinical descriptions to formulate the psychopathology of these two entities, which roughly reflects schizophrenia and bipolar disorder.
Yeah, I think when he was writing, and I think we see this a lot in historical medicine, it was a lot of case studies and finding similarities between cases as opposed to trying to categorize things so that we could study it better.
Mhm.
So now we're almost to an excess trying to delineate the statistically significant categorizational definition of these different syndromes and illnesses as opposed to descriptions, which is really what they did in the past.
Yeah, right. So Kreplin was more broad with the manic depressive insanity. He actually encompassed all possible expressions of mood states and believed it existed as a categorical spectrum, which we'll get into more later with Dr. Nasser Gami. He believes this also, that we are really underdiagnosing bipolar disorder. So he essentially included like these subdromal states also. And then skipping ahead again, in 1952, that was the first publication of the DSM 1, and they included something called manic depression reaction, which was actually considered part of a psychotic illness. Then schizophrenic reaction was synonymous with dementia praecox. So they had both of these conditions under psychotic illness. I think this is just important to highlight because we do see with bipolar disorder, especially bipolar 1, that's severe, there's a significant amount of delusions, hallucinations, psychotic symptoms. And so I think it's important to conceptualize it as there's a huge psychotic component that's associated with mania. A mania, when it's not to the extent of psychosis, it's, enjoyable. You're elevated, you're euphoric, you're going and being super productive, but then it comes to a point of psychosis, and that's always right around the corner. So I just think it's important to highlight that.
It's a really good point. And it comes up a lot we'll talk about it later in the treatment of bipolar disorder, is I've had many patients almost routinely, it's almost part of the illness, say, I wish I could be hypomanic for the rest of my life. I wish I could just sort of pause time in this hypomanic state. And it's true, you're more productive, you feel better, you're euphoric and excited and elated, you don't need as much sleep. But two things happen. Either the roller coaster keeps going up and there's no way to sort of pause it at a certain point, or what goes up must come down and you cycle back into depression. There is no way to freeze time at that level. And I frankly think that can feel disappointing.
Yeah, absolutely. So then in 1968, the DSM-2 came out, and they then called the manic depression reaction manic depressive illness. And it was now classified under affective disorders or mood disorders. So there was a switch in conceptualization here.
And that's still how they're classified.
Yes, right. Then in 1980, so just to make this very clear, the word bipolar disorder was never brought up until 1980 in the DSM-3. This was the first time that the term bipolar disorder was introduced, focusing on the episodic nature of the disorder. And they also differentiated unipolar depression from bipolar illness.
Those terms are synonymous. That can be confusing for some people, that bipolar disorder was the evolution of the manic depressive illness. So when people talk about manic depressive disorder and bipolar disorder, they're the same condition.
Right, right. Yeah. So if you run into our older psychiatrists, they might say, manic depressive illness. It's interesting because now there is an emphasis on the episodic nature, which was recognized in the past, but not focused on. Then they also introduced bipolar 2 in DSM-3, which included hypomania for those who had less severe symptoms. This is the part that's very interesting. Bipolar 1 disorder requires only mania. You actually don't have to have major depression with bipolar 1, but bipolar 2 disorder requires both hypomania and major depression. So then the question is there a separate entity that just includes mania as a unipolar mania? Does that actually exist? And I would love to hear what you have to say, Dr. Kelly, because in my experience, when there is just mania, and especially if that mania is severe, It's really hard for me to imagine that person then getting back to baseline and just living a neutral life, and then once in a while having that manic episode without some level of depression because it's debilitating. It's impairing daily functioning. So it's just a question of phenomenology. But yeah, what do you think about that?
What I've always been taught and what I believe and what I've always seen is no, is that there is no such thing as a unipolar manic illness where
Mm,
people are euthymic, occasionally get manic, and then come back to euthymia. There is
mhm.
always a depressive component, and it usually follows the pattern of the cycle. You very rarely go into either side of the cycle and come straight back to euthymia without at least briefly entering the other side of it. So people with bipolar disorder, even if they go into a depression, usually either before or even sometimes briefly afterwards, there will be a manic sort of bump.
Yeah.
But that can be the goal with medication management, is to soften the depression on the other side and to really rock solid stabilize that mood. But even then, I've never seen the phenomenon of someone who just has manic episodes.
Yeah, it doesn't make any sense because if you think about that sort of very elevated, euphoric, grandiose state, like let's say you're taking cocaine or something, right? It's this kind of like artificially very high state, and you come down from it. Coming off of cocaine is one of the highest risk factors for suicide. And
Yep.
so, just I think logically, it doesn't make sense that there is a quote unquote unipolar manic illness. So,
Mm-hmm.
yeah, very interesting. Then in 1994, we have the DSM-4, where the mixed episode was officially introduced, which complicates things even more. So
Substantially. Yep.
substantially. Right. So the mixed episode now is you're both manic and depressed, and it actually raises your risk of lethal means of suicide pretty significantly because now you have energy. You're not only depressed, but you have the energy to act on it.
And we'll talk about this a little more later in the diagnostic uncertainties, particularly around children. But I think the introduction of the mixed episode really opened up the idea that irritability can be a core feature of manic depressive illness, of bipolar disorder. And so a lot of people with more chronic irritability were now being labeled as people with bipolar disorder with sort of chronically mixed episodes, which we now think is incorrect, but it led to a lot of diagnostic confusion. I'm not saying that there isn't mixed episodes. I actually think that's fairly common, but it's not the hallmark of the illness that for a brief period of time it seemed to be.
Right. Also, referring to bipolar disorder as possibly present in children has been around since the 80s. It's been in the DSM. It's just it hadn't been highly focused on. And then in 2013, with the DSM-5, now mania requires not only increased energy, but goal-directed activity. So you have to objectively see that they're doing more things. DMDD was added, which we'll get into. That's a whole nother thing with irritability and all of that. And then they added a medication component that if you are on an antidepressant treatment and it triggers mania, then it also counts as evidence for bipolar 1 disorder, which is very interesting if you think about when psychopharmacology blew up. It was in the 2000s and 2010s. All of these antipsychotics came onto the scene, the newer generation ones. It puts into perspective that the DSM is reflective of what's being advanced in medicine. This also tells me that it has a lot of room for adjustment in the future, depending on what tools we have for treatment, right? Like, let's say we have more neuromodulation or something, it can change the definition of mania.
Right.
Yeah.
I mean, I think that's important to remember that these are all human created concepts that we as people are trying our best to define and categorize what we see in nature. We take the best ideas at the time, but it's sort of a cyclical feedback loop that we think we're seeing more of one thing that becomes established. We sort of change our criteria and are more on the lookout for it. And so we see more of it. And then that sort of further refines or changes the criteria. And so there's a lot of I don't want to say pop culture, but there's a
Mhm.
lot of what's popular at the time that goes into creating these definitions, which then makes it more likely that we'll see those things. It's all people just trying to do our best to define this. This is not through sort of perfectly factual eyes that we're seeing this.
Yeah, I think in other fields of medicine, it's not as noticeable. I think if you dive into it, like for example, I didn't realize that there's no standard intravenous fluid formulation that's recommended for ICU patients. There's no standard.
Hmm.
There's a couple of different options. Something like that, you kind of have to delve into a little bit. But with bipolar disorder, that's like a huge area that we work on, and we still don't have straight answers. It's quite frustrating. But I think for patients and general public out there, we do know that there is a pretty significant impairment in daily function that comes from mood episodes, whether it's like high episodes, manic, hypomanic, or really low episodes, depression, major depression. Because of the conditions we see, we can recognize when something is really off, like there is some underlying affective disorder happening. So I just
Hmm.
want to reassure people that we're not just like guessing.
Right. Yes, absolutely true. And humans are good at pattern recognition. That is one thing that we as a species are really good at. So my point was that if you are diagnosed with bipolar disorder, that the definition of that condition may change over time, in addition to your symptoms may evolve over time. So we do our best to give diagnostic criteria and definitions, and we are good at what we do. But there has to be an openness that these are not 100% perfectly fixed.
Mhm. Yeah. So, discussing a little bit further the diagnostic challenge, this ongoing controversial topic, which is this idea that we are massively underdiagnosing bipolar disorder. So,
Mhm.
there's key figures in the field. So, Dr. Nasser Gami is very famous for this proposition that we misdiagnose a lot of people with unipolar depression when they're actually on the bipolar spectrum disorder. So this is going back to Emil Kreplin's manic depressive illness, that there's a lot more people struggling with manic depressive illness than we think. And
Mhm.
as you're saying, Dr. Kelly, you may not have manic episode yet or hypomanic episode yet. You might just first present with depression. So it's a decent argument. And he specifically talks about this in the context of, for example, differential diagnosis of bipolar disorder includes ADHD. And so there's a tendency for the DSM to add a bunch of different diagnoses, such as depression and ADHD, when it may be under the same umbrella of bipolar spectrum disorder. So instead of adding on a stimulant for ADHD and then an antidepressant for depression, if you add a mood stabilizer, such as lithium, then you
Mhm.
may treat all of those conditions. So
Right.
that's just like one example, but he has been pushing this idea of it's a bigger, broader category and more people need to be aware and the stigma needs to be reduced about bipolar spectrum disorder. And there's even like a task force that looked at antidepressant use in people with bipolar spectrum disorder. And they basically said that they couldn't endorse antidepressant use, but acknowledged that some people with bipolar disorder benefit from antidepressants. So it wasn't completely removed off the table. But in bipolar 1 patients, antidepressants should be only prescribed as adjunct to mood stabilizing agents.
Right.
So, yeah, it's very interesting. So I think my thoughts about this is that it is a very biological approach. And as a child psychiatrist, it is very, very hard to accept this at face value because we know that there is environmental stuff, there's
Mhm.
family conflict and abuse and all of this stuff that plays very much into the child's symptoms. But I know he's more of an adult psychiatrist. So, you can remove yourself from that a little bit more, but just a little bit more. Everybody's
Right.
still living in the context of an environment. So it's hard for me to really accept, but I do appreciate his like fervor and passion in trying to reduce diagnoses because I do agree with that. I think there's a bunch of diagnoses that we don't need.
Yeah, I think the focus on formulation as opposed to diagnosis, I totally get. And looking more broadly, I think there are elements of what he's talking about that make a lot of sense. And just because you meet criteria for a diagnosis doesn't mean that it captures the underlying sort of syndrome or picture really of what's going on. But I just,
Oh,
anyone who so pushes any single solution for a group of patients makes me nervous because I think that it's so important to focus on the person sitting across from you and not lose sight of that and not try to see that person through the lens of so many people are underdiagnosed or overdiagnosed or whatever. I'm going to be the one to catch it. Then your sensitivity is so big, you lose the specificity, right? So I don't know.
yeah. Yeah, I want to like clap to that. Yes, totally. The audience can't see this, but I'm like really trying to clap here because it's so true. It's almost like you have to read the whole DSM like 5 times, and then you have to read all the textbooks, and then you have to let all of that go when you sit across the room from someone in a one-to-one session and you're listening to them. You really have to let all of the diagnostic criteria and the check marks and the lists go. You have to listen to what and how they're saying things and what they're trying to communicate to you and the body language and the reading between the lines. I think all of that we have no way of quantifying right now. We're working on it, but we're not quite there yet. But as a clinician in the field, you recognize that and you use it. And so I think it's just so hard to simplify things into this one giant one size fits all. It just doesn't work like that. There's 8 billion people in the world. You can't apply a one size glove to everybody. But I was also going to say that it's very interesting because of his biological approach. There is an emphasis on medications, which I think is fair because we do benefit a lot from medications. But I think that's where I kind of struggle because I don't think it's all about medications. I think, in fact, medications are probably like 50% at best. There's a whole chunk of psychiatry that's missing if you're hyper focused on this approach. So,
I mean, especially in children and adolescents, right? There's so much that is not pure biology and that can be both caused by and from a treatment perspective influenced by how you change the structure around them and how you influence the whole system.
right. So, speaking of bipolar disorder symptoms in children, oh, this is so hard
Well,
because
this is where it gets hard, I think, is you're trying to talk about what the differences are and what it looks like. And the honest truth is, even among the very highest experts in the field, it's all over the place. And there's
Mhm.
wild disagreement about what bipolar affective disorder looks like in kids, let alone what it looks like before the first episode, right? People have been trying forever to see what the precursors might be and what the hallmarks might be and the risk factors. And a lot of the evidence has simply proven that we're wrong. Chronic irritability, even euphoria, is more likely to lead to either depression or anxiety as an adult than bipolar disorder later in life. So the truth is, we're as a field trying hard, and we should be, but we don't know yet. And people build whole careers off of trying to figure this out. And some would argue that even then, if your whole stake, all of your funding is based on saying, I know what bipolar looks like in kids, you gotta push that you know what bipolar looks like in kids, even if your evidence starts to show, maybe I don't know what bipolar looks like in kids. So it's
Right.
very complicated.
Right. Yeah. I mean, it's your livelihood. It's the critique of academia, right? It's that
Hmm.
like once you start down a path, it's your livelihood, it's, source of financial stability. I mean, it's understandable, but we have to really push for objectivity here. Um,
Yeah.
so it is very difficult to identify pediatric bipolar disorder. The big symptom that comes up over and over again is irritability. And people have suggested that it could be a core feature. People have argued against it. But so let me actually just define irritability because it's just a very common term. Irritability for us, it means having a low threshold to anger. faster increase to anger, and a higher peak of anger, and then the longer duration of anger for the age range that you're at. So this is developmentally comparable, but it's quick, it's really intense, it lasts longer, and it's abnormal from the child's usual presentation. So that's the definition of irritability that we're working with.
And that's actually a good point. It can be unusual for the age norm of the population, or it can be unusual for the kid. It can be sort of episodic, where they go through episodes of this heightened irritability that then resolve and they go back to their baseline. So either one, right? Someone who's a perfectly calm, zen child who becomes normally, quote unquote, irritable would be unusual for that person. And so that can be irritability, or someone who's chronically at this extremely heightened state of irritability. That is their norm, but that's not a norm for the population at large, can characterize irritability.
Yep, right. So a recent meta-analysis, which is kind of our highest level of research, on about 20 studies showed that the most common symptom across all bipolar subtypes in children were increased energy with 79% and irritability with 77%. And then mood lability, which means your mood goes up and down, was 76%. And then just last thing is distractibility was 74%, which reminds you of ADHD, which is often, confused with bipolar disorder. So this is why irritability is important. It is just something we see in bipolar disorder in children. It's not necessarily specific, but it is common. So low specificity, but very common. Mm-hmm. So therein lies our confusion, but it's something to pay attention to. And with irritability being important, the reason that was brought up was because prior to DSM-5, there was a burst of introduction of antipsychotics as mood stabilizing agents for bipolar disorder. And then the prevalence of the diagnosis of bipolar disorder in youth exploded. So between 1997 and 2003, the number of people younger than 18 diagnosed with bipolar disorder increased 40-fold. 40-fold.
40-fold. Yeah. I've never seen anything like that.
Right. And we talk about autism being more diagnosed these days, but bipolar disorder back in the late 90s and early 2000s was very commonly diagnosed in youth. And so the concern was that we were overdiagnosing bipolar disorder in youth. And this is a lifetime diagnosis. So once you have it on your chart, it's going to stay with you. And it's a huge cause of disability. It may be dubbed as a pre-existing condition, which, then the insurance companies are biased against. It was a big problem. So then the DSM-5 introduced the disruptive mood dysregulation disorder, or DMDD, to try to address this high rate of potentially false positive pediatric bipolar disorder. And the idea was that the irritability, which is a core factor of DMDD, may be something that exists separate from bipolar disorder. We see it a lot in bipolar disorder, but we shouldn't jump into diagnosing bipolar disorder. We should probably put a pause button to that and diagnose it as DMDD, and then wait and see how it unfolds as the child develops. And so DMDD, essentially the diagnosis requires a chronic irritability. So it's always there. It's relentless. It's pervasive. Doesn't matter what environment the child is in. And on top of that chronic irritability, you have temper tantrums, really severe outbursts, angry, emotional outbursts that are disproportionate to the initial stressor. So that's the definition of DMDD. Now, DMDD has a lot of debates. And also, we have to be very cautious about relating DMDD to bipolar disorder. Just because it was used to kind of put a pause button on diagnosing bipolar disorder in kids doesn't mean that it's a precursor to bipolar disorder. In fact,
absolutely.
Right. In fact, it's much more of a precursor for major depression. I
Yeah, I think through this, it does seem like there was a big confusion about taking a single symptom and trying to deduce the diagnosis behind it. It's like if everyone who came into the emergency room with a fever, we assumed that you must have XYZ, right? Or named febrile illness, which can be comorbid with flu. Right? Like it doesn't fully make sense, but we are trying to do the best we can to help kids. And there is the idea of early intervention and early treatment and kindling. So the
Mhm.
earlier you catch and treat bipolar disorder, the better the course of illness over time. So I think people are trying to be helpful, but I think there's no way for it not to catch too many cases.
Right.
And we know there can be differences. So there was a big study, I think in 2008, comparing geographical predilections towards diagnosis. They compared United States trained psychiatrists and United Kingdom trained psychiatrists, and they gave them a number of case vignettes of essentially irritable children. And the United States psychiatrists were far more likely to diagnose bipolar affective disorder than the United Kingdom psychiatrist. So there's even sort of a geographic bias towards bipolar disorder at the time. So yeah, it just reminds me that we're not looking at these kids through the term I want to keep using, but it's a loaded term, is we're not looking at them through God's eyes, right? Like
Mhm.
we're not seeing as humans, oh, I can divine that you have bipolar disorder and will always have bipolar disorder. You just can't say that to a 12-year-old.
Exactly. That's a very good point because it's kind of like how science works. We don't necessarily always know etiology or like why, but we just describe things. We
Mm-hmm.
we just put feelers out there to categorize things and bunch things up so we can think about them more coherently. But we don't have a crystal ball. We don't have a big picture idea. We just know that people suffer.
Yeah, and I think one way that's been helpful for me to think about it is so Gabrielle Carlson is a child and adolescent psychiatrist. She was the president of the American Academy of Child and Adolescent Psychiatry a few years ago, and irritability was really an area of interest of hers. And so she pretty much defined the term of impairing emotional outbursts for these sort of severe tantrum like episodes that get in the way of children's and families' lives. And rather than focusing on where are these coming from necessarily, that is a parallel process of how do we make these better. So ACAP has a medication guide, a resource center on impairing emotional outbursts. So sometimes focusing on function can be a very helpful approach rather than trying to live solely in the world of defining the etiology of these, because sometimes we're wrong. And
Mhm.
so focusing on improvement can be a very useful approach.
Yeah, right. You get hung up on it and you kind of obsess over it. Is it this or that? But really, working with what's in front of you is what matters. Okay, so the difference between DMDD and pediatric bipolar disorder. We were saying that the DMDD is a lot more of a chronic irritability, it's very pervasive, whereas most psychiatrists agree that pediatric bipolar disorder has an episodic presentation, the irritability, the elevated mood, the increased goal directed activities, increased energy. It's more episodic.
Right. And they separated depressive disorders and bipolar and related disorders because the other outcome of diagnosing so many people with chronic irritability with bipolar disorder is it makes you much more hesitant about using antidepressants, which can be very effective for patients with DMDD.
Yeah. And I guess for the pharmaceutical industry, DMDD was not the greatest thing, right? Because now you're not diagnosing pediatric bipolar disorder. You're not using these newer generation antipsychotics. It's an interesting consideration to look at what is happening in the market.
It's always so fascinating. And I think we try to stay away from that as much as possible in the practice of medicine. Best thing for the patient, regardless of finances and what things cost. But the reality is that we live in the world where companies manufacture and sell pharmaceuticals to make money. And
Mhm.
that it doesn't have to be that is inherently nefarious, but it's important to always consider what are the reasons that a pharmaceutical representative is in my office
Hmm.
saying, we have a new treatment for bipolar disorder. By the way, how many bipolar disorder patients have you seen? And maybe we can help your patients feel better. Like, that's my job. I help my patients feel better. But thank you for your input.
Right. The incentivizing, right? Yeah. So now we want to move into differential diagnosis because oftentimes pediatric bipolar disorder looks like a lot of other things, the most common of which is ADHD. So ADHD is our bread and butter. We see them all the time. The understanding of ADHD is that it's dependent on your environment. Like, let's say if you are a math nerd and you specialize in STEM careers where you're focused on science, math, and then the demands do not exceed your kind of supply of attention. But if you are an artist and you have to complete physics for whatever reason, then it's really, really hard to maintain that focus and attention. So there is a inherent developmental aspect to it, and then the environmental triggers facilitate the manifestation of that disorder.
Mhm.
Another disorder that we often confuse bipolar disorder with is major depression. With adolescents, especially, depression can show up as anger, irritability, because they really don't want to feel sad. They don't want to feel quote unquote weak. They don't want to cry. There's kind of a resistance to this sadness feeling. I know better. I'm almost an adult now, especially if you're a teenager, right? So
Mhm.
instead of the sadness, you feel this intense irritability at every little thing. Your little brother knocked over a cup and you just explode. And it's not that that is the thing that caused the anger explosion, it's that things have been piling up and it was just the last straw. So schizophrenia and psychosis is also on the differential because, with bipolar mania and bipolar 1 disorder, you do have the delusions, hallucinations that's fairly common with truly manic episodes. But with schizophrenia and psychosis, obviously the psychotic symptoms are persistent. So it's not episodic. Some level of ideas of reference or delusions or paranoia is always there. And then autism spectrum disorder is another misdiagnosis.
Yeah, I think when I thought of that, I actually thought that it's not uncommon.
Mhm.
I see many, many, many young people with DMDD, intermittent explosiveness, the idea of waking up and seeming like a different kid on certain days, where sometimes parents are told, and sometimes through their own research, they think, gosh, my kid may have bipolar disorder. And a lot of times it's extreme sensory sensitivities, extreme dysregulation, and internal sensitivities to even internal stimuli that we might not be able to see because for someone with autism, if they hear an ambulance siren go down the street, their day is over. Or if they are in the bathroom when the toilet flushes, the sound of that toilet is like setting off fireworks in their brain. They just don't know how to tolerate it. But to someone without that condition, we wouldn't even consider that a trigger. So it
Mhm.
seems like they fly off the handle for no reason, but really it's just that we don't appreciate the triggers because to a certain extent they're living in a different sensory world. So I've absolutely seen the misdiagnosis of bipolar disorder in kids with extreme sensory sensitivities in that way due to autism. Or there's sort of a misunderstanding of social interactions that we take as so normative that it can seem like mania. If you're just having a good old time and everyone around you is at a funeral and crying and you just don't appreciate it, you're not manic. You're just in your own world. So I think there are a number of ways where it can be misconstrued as bipolar disorder. But
Mhm.
as you've said, a lot of the continuity is the key that somebody is chronically stably unstable, that instability and reactivity is not something that fluctuates that much. Whereas someone with bipolar disorder, the irritability should come in episodes. I think another confusing thing when we talk about episodes is that in bipolar disorder, a lot of time an episode is episodic, but the episode persists. It's not an
Mhm.
episode of an hour, it's an episode of days to weeks. So
Mhm.
if somebody has a tantrum that lasts 2 hours, that's not mania. That's an expression of irritability.
Mhm. Yeah, I forgot to mention that. When we say episodes, we mean days, weeks, even months sometimes. But you're right about the kind of concreteness that comes with autism, right? That if something isn't going the way they want to, there's overwhelming response to that, the black and whiteness that comes with that. Yeah. And so of course, we do have to mention PTSD or complex PTSD, and then relatedly, borderline personality disorder. These conditions are also often misdiagnosed as bipolar disorder because of the mood swings that come with oftentimes triggers. And these triggers can be unconscious. It's certain smells or a certain texture or a certain visual stimulation that you are not conscious of it, but the body keeps a score and it activates that fight or flight response. Specifically with borderline personality disorder, I think that is actually a little easier to see the difference because there is a very deep sense of low self-worth, extremely insecure, self sabotage, self harm, and suicidality, which also occurs in bipolar disorder, but it's more so deeply rooted. And if you look at the overall presentation of that person, it really starts with that low sense of self.
I think that could not be more true. And I think that that can sometimes be hard to see because people will tell you it sometimes on careful questioning, but a lot of times that has to be interpreted because there's so much defense around that low sense of self that it can come across as egotism or be misdiagnosed as narcissism because they're so defended against threats to their sense of self, which is already so low.
Yeah, totally. And lastly, we have oppositional defiant disorder, which, again, personally, I don't like this diagnosis, but I understand that it exists. So with ODD, it's a little more specifically difficulty with authority figures, and also there is an intense vindictiveness. And I'm not necessarily just saying, okay, parents are putting limits and the kid pushes against that. It's this kind of active planning out and deliberately being vengeful, getting back at someone to spite someone. So when I see that chronically, I do think more about ODD. But I mean, I can almost always find reasons behind the vengefulness and vindictiveness. It's not that kids are inherently that way. That's more like conduct disorder, antisocial personality. That's extremely rare. We're talking about like people on true crime shows and psychopaths. But that's so rare. Most of the time, kids have some reason for feeling really inadequate and then therefore externalizing that into behaviors.
I could not agree more with that. And I think it it gets to a core downside of the way we talk about diagnoses, which is that a diagnosis lumps together many different concepts and I think can be misunderstood. So a diagnosis can be sort of an underlying syndrome, like someone has a, God forbid, a stroke, right? You know what a stroke is. You can see it on an MRI, you know what it is, you know what it leads to. We know that exists as an entity. That's a diagnosis. For our purposes, a diagnosis can also be a way of relating with the world, which may have various different causes, various different etiologies that statistically it hangs together, and we call it diagnosis. So I think calling oppositional defiant disorder diagnoses misses a lot. Oppositional defiant disorder is a characteristic of having intense oppositional behavior towards authority figures that usually comes from somewhere else. People don't fall out of the womb with that as a trait. Whereas bipolar disorder, we think, is a core biological feature that someone will almost always have the propensity towards depression and mania in an episodic nature. And I have a lot of parents who come in, and one of their core questions is they were diagnosed with oppositional defiant disorder. What does that mean? We're really upset by that.
Mhm.
And I have to roll that back and say, this is not a core feature of this person that we've just discovered for the first time. This is just a description of how they're behaving right now. That's
Mhm.
convenient and gives us a shortcut to talk about all these different behaviors in one word. But you have to treat it by figuring out why it's there and where it's coming from. You don't stop at oppositional defiant disorder.
Yeah, so true. And the diagnosis doesn't tell you what's going on, right? Like what is the story here? What are the circumstances? And you need the what's going on to then move into treatment. So, when you say ODD and then you say behavioral intervention, okay, well, what's in the behavioral intervention? You have to actually know all the details surrounding what happened at school, what happened at home, what's the family dynamics like, what's the sibling dynamics like, all of these things. So, yeah, I completely agree. And we do have also medical diagnoses that we just have to consider. And some of these include head trauma. So TBI can lead to a lot of mood swings. Hyperthyroidism, this is kind of your classic medical school question. Check the TSH and T4. And then corticosteroids. So actually, I think this one is relevant because I do have some kids who have asthma and they are on as needed albuterol. And sometimes they'll go through like a week treatment of steroids and it will give them that sort of activation and they are extra edgy.
Yeah, that's so critical is that I hope this doesn't go against what I just said about the complexities of the human experience, but we're all bags of chemicals walking around, and if you introduce new chemicals, things are going to change. So yeah, we can't separate those two out.
Yeah. Yeah, that is a philosophical discussion, Dr.
Right.
Kelly. I could get it down to atoms and electrons, but yeah, no, definitely. If the chemistry is changing, there's definitely something that comes with that, especially in kids. Yeah. Okay, so if you are at a point where you're like, do I have bipolar? Does my kid have bipolar? You definitely want to bring that person or bring yourself to a psychiatrist. That is a level of severity that we address.
And I think if you're looking for other things to do in that process, the very first thing that the psychiatrist is going to ask is about the pattern of symptoms over time. And there are mood tracking apps, there are mood logs, mood charts. So one of the old sayings in medicine is if the first thing you want to do is change something, start observing it and start keeping records about it. So just observe how it is now before you try to change it. So just putting a stake in the ground and starting to track mood on a daily, weekly, monthly basis can be extremely helpful. I think if someone came in for an initial assessment to me with 3 months of mood logs, that what a gift.
Oh, what a gift. Yeah. Wow. I've never had that happen, but
No.
that is amazing. Okay. We want to talk thoroughly about treatment options and strategies because it is a very important part of this. So, there are differences between acute management of mania, acute management of bipolar depression, and then maintenance treatment. So, this is relevant because there's different dosages, different approaches to different parts of the bipolar disorder illness. So the first line is monotherapy, meaning that we try to use one medication as much as possible for acute management of manic or mixed episodes. For kids, the first line is second generation antipsychotics. So these are medications like risperidone, aripiprazole, quetiapine, olanzapine, and also recently approved asenapine. So, of these, aripiprazole or Abilify has shown pretty significant improvement in manic symptoms and overall bipolar symptom severity compared to placebo. I also feel that Abilify wears a lot of hats. You can use it for autism, aggression, agitation. You can also use it to kind of boost the effects of antidepressants as an adjunct.
And I
Yeah.
think they can all be effective. And if you look at the different studies, different agents are used. And we'll get into some of the mood stabilizers, but for our listeners who are maybe trained in adult treatment or who have bipolar themselves, they're thinking, what you just talked about how some of these newer agents were used to push the diagnosis of bipolar to sell more of them by the pharma companies. Why are we going back to talking about them when things like lithium Depakote have been around forever and are still first line in adults? And the answer is simply in the evidence. Huge meta-analyses, Cochrane studies, both in the United States, international, have repeatedly shown that for acute treatment, the fastest acting agent to reduce symptoms are the second generation antipsychotics. That's it.
Mm-hmm. Yeah, there's pros and cons of working with pharmaceutical companies because they make these studies happen quick. They've got the financial resources to do it. Academia will take 25 years, pharmaceutical company will take like two. So yeah, we definitely do have to work with them. But you're right, medications like lithium, it's dirt cheap, it's generic. There's not really a purpose in investing in randomized controlled trials. But the thing about some of these anticonvulsants, lithium, Depakote, Trilaptol is another one, they do have side effects. And
Hmm.
oftentimes you have to monitor blood levels. So for lithium, you have to check blood levels to make sure it's in therapeutic range. It also has some long-term potential adverse effects, impacts on the kidney and thyroid. And so in kids, we do prefer some of these second generation antipsychotics just because also of the side effect profile. It's just
Hmm.
generally safer. So lithium is considered second line for kids, but it is approved for mania and mixed episodes down to the age of 7. Again, childhood bipolar disorder, it's debatable, but it is considered to be effective.
One of the great benefits of being around for a long time. If they've done studies down to the age of 7 and it's approved, you at least know it's safe, right?
Yes.
Because safety comes first.
Yeah. And then with the anticonvulsants, so we're going to say a quick word or two about them. There's a lot more behind this, but I think the goal is to give the audience an idea of why we lean one way or another. So Depakote is generally fairly effective, but we do tend to use it more in boys or males because of its teratogenic effects. It can affect the fetus. Now, we're not saying that these teenagers are potentially pregnant. That might not be the concern, but it is a potential adverse effect. So we try to steer away from the possibility of that.
Yeah, and lots of young females who might be going through mania for the first time are in pubertal age, and it can predispose to PCOS symptoms. So it has a lot of secondary hormonal effects that we just want to be cautious about.
Yeah, yeah. And then carbamazepine also does show some effectiveness, although I think with carbamazepine, there's that auto metabolism and the effectiveness wears off over time. So it's not usually my go-to. Same kind of thing with oxcarbamazepine, which is trilaptol, although it does seem like when there is a little bit more of a personality going on, that some of these anticonvulsants, lamotrigine is another one, they can be quite helpful in stabilizing the ups and downs associated with personality.
Hmm.
And then moving on to acute management of bipolar depression. So now we're on the other side of the polarity of major depression. There's limited evidence in the management of bipolar depression in youth, probably because the data for research for people under 18 is limited. But lurasidone or Latuda has been found to be effective for bipolar depression in youth. And then the olanzapine and fluoxetine combination has also been effective. This is one of those examples where the olanzapine fluoxetine combination, which the brand name is called Symbyax, is really expensive. But if you just get olanzapine and fluoxetine separately and take them together, it's very cheap. So this has been used together to treat bipolar depression. This is going back to the point of there is a concern that an SSRI can induce mania, but sometimes it is beneficial for someone with bipolar depression. And so this is an example of that.
Hmm.
And then maintenance wise, I think the only thing that I would say is you oftentimes can take people off of certain medications once they've reached a stable mood. And also, you can reduce the dose. So, just to talk to your psychiatrist and really pay attention to the warning signs. Usually, it starts with not being able to sleep very well, not being able to rest. There's a hypervigilance about everything. So the maintenance dosing is very different.
Yeah, and I think it's very tricky to work with your psychiatrist to find the appropriate maintenance dosing because it's sort of like if you get asthma, right? And a lot of times the way you measure that is asthma attacks in a certain period of time, and if people have breakthrough asthma, and that's how you figure out what they need for maintenance. With bipolar disorder, it's much more tricky because someone may have a true episode every few months, once a year, once every few years. So fundamentally, it's really hard to make changes looking for a negative, right?
Hmm.
Like you know that the maintenance is not necessarily where it needs to be if somebody's having episodes. But if
Right.
somebody's not having episodes, that doesn't mean that the maintenance dosing is right where it needs to be. You may just be catching them between an episode. So it can take a very long time, and it's a very slow, cautious process to find the correct maintenance dosage for someone.
Yeah. And I think also with bipolar 1 disorder, because mania can feel good, there might be a preference to go down to that maintenance dose a little bit early. And so, talking thoroughly about what are the risks, benefits, side effects is important.
Mhm.
So, with kids, one of the most important things is psychosocial interventions for bipolar disorder. There are different ways to approach this, but there is a focus on the family component, and there are specific psychosocial interventions. One is called family focused therapy, FFT, and then also family psychoeducation. Psychoeducation is so important for pediatric bipolar disorder. It's the not knowing that really drives families apart. And when you don't have that social network, social scaffolding as a safety net, the bipolar illness gets worse and worse. So, FFT has been the premier treatment in terms of psychosocial intervention, but it is hard to find programs for this. I've personally struggled here in Los Angeles to find programs without like a 3 month wait list. So, it's really hard. And then, of course, we do have CBT. CBT can be effective in so many different conditions, including bipolar disorder. I would say that probably CBT would need to be brought on more when they're stable and to include that cognitive reframing and stopping the automatic negative thought processes, because when they're manic or when they're really severely depressed, it could be a little bit difficult. But that's when DBT comes in. DBT works specifically with really severe highs or lows, and it regulates that. That's the whole point of DBT. So there's skills, mindfulness, grounding techniques that can be really helpful.
I think if you're not able to find FFT, that doesn't mean that CBT and DBT are second line. They're all evidence-based, they're all very effective. I think that FFT with the family involvement is being more recognized as highly effective care. So if it's locatable, that's fantastic. But good care that you can access is the most important consideration. So
Yeah.
if you have to get on a plane and fly once a week to get FFT, don't do it. Go
Yeah.
to an excellent, reputable CBT, DBT, or other psychodynamic therapist close to you.
Yeah, actually, I was going to bring that up that psychodynamic psychotherapy has been shown to be helpful because I think it's a very primitive thing with people can always tell whether you care or not, whether you're present or not with the person. And whether you have bipolar or not, or schizophrenia or not, any of these serious mental illness, they can always tell that that is something like viscerally felt in the experience, in the dyad, in the one-on-one interaction. So I think psychodynamic approach is also very important. I was also going to say with FFT too, you can sort of make your own team of experts. Like, yes, you might not be part of a program, but you've got a psychiatrist, a therapist, a family therapist, a caseworker, family physician, specialists. So you can formulate your own team and also request that your providers talk to each other, because I think that's also important. I do this all the time where if we collaborate, there's more of a sense of you've got a team behind you and we're here to back you up.
Yeah, I would argue that it's essential. I'm always saddened if I'm talking to a therapist and they say, "Wow, you're the first psychiatrist who ever called me back." Or, families who will say, "Well, here's the therapist that we're seeing. We're happy to take any information you need." And I have to say, "No, I'll talk to them. That's part of the job of making sure that everyone's on the same page."
Mm-hmm. Yeah, that really makes me upset too. I don't know if it's that there was kind of a leaning towards biological psychiatry that fueled this, or if it's that, I don't know, there weren't enough people applying into psychiatry. And so you don't necessarily have people who are like really passionate about psychiatry. I don't know what it is, but I totally hear you. It blows my mind when therapists, nurses are like, wow, you seem to care. And this is kind of a critique on the whole field, but I do think there's a way in which you can do the bare minimum and just get by with psychiatry. You can do the bare minimum. You can see someone for 10, 15 minutes, prescribe the medication, and walk away. And it's absurd to me, but you can do that. It's frustrating.
It is frustrating. I think that that's bad care. I don't know what else to say about that. I think, yes, that is technically correct. And sometimes that's what people expect, that you walk in, talk for a few minutes, get a medication, and walk out. But you're missing almost all 80% of what you're actually doing with the psychiatrist and what they're there to help you with. It's not simply medication management. And sometimes I hear, "Oh, are you the one who gives medications?" Like in the psych world. Is that what you do? And I do think there's a bit of a confusion because in the mental health field, prescribers are the only ones who can prescribe medication, but that doesn't mean that is all we do.
Right. Yeah, exactly. And that also reminds me of there are pressures from insurance companies, insurance claims, hospital administration to see as many patients as possible for a psychiatrist, right? Because you are the only person that can prescribe these psychotropic medications. So there is a pressure there. But I guess that's what I'm pushing against is that maybe we need more studies to show that, the approach of the psychiatrist makes a huge difference in the effect size of the primary outcome of the treatment. We do know that for therapists, research has shown that it's not necessarily the therapy modality, but it's the therapist that has the most effectiveness on the patient's outcome. So there's something about the person's approach, that specific person's approach, that is huge. And I think this is one of those things that we've known this for centuries, but we just don't have research evidence to prove it. And so maybe we need to do more kind of exploration of what the individual psychiatrist and their approach and how that makes the medication effective. I think there's actually a book called Listening to Prozac where, yeah, it talks about this exact concept that Prozac medications, SSRIs, maybe 60% of the people find benefit from it. But what are the factors that contribute to that? Because there's a large percentage of people who don't find any benefit. And a large part of why there is benefit is that the psychiatrist that you're getting it prescribed from cares about you. So, soapbox, but yeah.
Extremely important soapbox. And I think a soapbox that's not talked about enough. So thank you for talking about
Yeah, yeah. Okay, so final takeaways for pediatric bipolar disorder. This is highly controversial. It's very complicated. We don't have answers for what is a cardinal symptom or what is the core feature of pediatric bipolar disorder. But we do know general patterns, we know general trends, and we also rule out all other differential diagnoses, psychiatric and medical. We want to keep in mind this dual track approach of there may or may not be a biological bipolar disorder going on. And then there's also social aspects, psychosocial aspects, environmental issues that could be contributing to the irritability or episodic elevated or low moods.
Yeah, I think although diagnosis is important, it's easy to get hung up on. Is this bipolar? Is this not bipolar? Where does this come from? And I think in that dual track approach, we can work on improving function and helping people do better while we're still honest about the fact that we're figuring it out. That this is likely bipolar or unlikely to be bipolar, but remain open to the possibility on either side that further data, further evidence will convince us one way or the other. And we can still do things in the meantime.
Mm-hmm. Yeah. We want to remain open-minded. That's a big part of this. And we also want to see objectively how much the DSM has changed, how much the conceptualization has changed over the years. We have a long ways to go, but that doesn't mean that there's no help for people who are struggling with potential bipolar disorder.
Yeah, I think you've hit on something that's really important, which is that certainty is always more satisfying, even when it's wrong. That
Mhm.
there's a temptation to jump to, I know what's going on, or to get that diagnosis or get that explanation for what might be happening, even if it turns out to be incorrect. And I'm not going to jump on another soapbox, but I think unfortunately a lot of keys to success in politics and other areas of the world is just being certain and convincing, even if you're not right, or even if you don't even know if you're right. And that can sometimes overshadow those of us who look at the exceptions and really want to take a broad view and want to avoid premature closure and be more careful and think, well, that might be true in some situations, but it might not be true in other situations. It can seem like we're indecisive or we're waffling, but there's so many examples of jumping to a conclusion that turns out to be incorrect that is way more harmful than being a
Hmm.
little more open. So that's why I like the idea of the dual track approach is saying that we don't have the answer right now doesn't mean we're powerless to help. We're still collecting data while we're using interventions to make things better. I think is a really useful approach as opposed to saying, yes, your 7-year-old has bipolar disorder. They will always have bipolar disorder for the rest of their life. Here is your lithium prescription with infinite refills because you'll be taking it until the day you die.
Yeah. Yeah. Imagine being a parent, right? Hearing that. It just, your world collapses. But yeah, that's very well said about the people like uncertainty, even if it's wrong. That's pretty powerful. It's the weight of that, right? Yeah.
Hmm.
Yeah.
It's true. It's easy to say, no, this is correct, and to
Right.
really throw your weight behind it. And if
Yeah.
people don't look too closely, you can get away with it, even if
Yeah.
you're wrong.
And the kind of humanness of that, the flaws of that. Yeah. We always have to take a step back from the lens through which we see things.
Hmm. This information is constantly evolving. This
Oh,
is our
yeah.
understanding at this point in time, but information is always updated. So we do have a few good evidence-based, patient-focused, parent-focused resources. We can put them in the show notes, but American Academy of Child and Adolescent Psychiatry, American Psychiatric Association all have resource centers and really excellent educational material on bipolar disorder in children that is evolving in real time.
Yes. Okay, great.
That's a
Yeah.
wrap.
That's a wrap.